Welcome to the Fix Your Sciatica podcast, where we meet with experts and clients and discuss how to manage your sciatica and low back pain without the use of medications or surgery. I'm your host, Dr. Ashley Mack, and I'm a physical therapist as well as the founder of ifixyoursciatica.com, a go-to resource for pain management. One of the uncommon areas that I look at when I work with clients who are dealing with sciatica pain are their feet. And why is that so important? It's because of the fact that the feet that we walk on are very, very similar to the tires and wheels that we use when we're driving. It's our connection to the ground. And I would be remiss if I overlooked that, because there's a huge role in regards to how the foot interacts with the rest of the body. And it's also its interaction with sciatica pain. And I thought today's guest would be particularly appropriate and the expert in it because he is a doctor in podiatric medicine. So today I have Dr. Keith Chittenden out on the East Coast talking all things foot and biomechanics. So good morning, Dr. Chittenden. How are you doing today?
Thank you very much for having me on your podcast. I'm doing fantastic out here.
Awesome. Yeah. And thank you so much for being taking the time out of your day to be able to share your expertise with our listeners.
Absolutely.
If you could, can you tell us a little bit more about yourself and your journey to where you're at today? Because we connected via LinkedIn, and I thought your background was particularly exciting, being that you, I'll let you share everything with the listeners. Go ahead.
Sure. My journey has been, quite interesting. I've had a lot of different turns and stuff in my career. I first started as a personal trainer, and I was training in a club called New York Sports Club out here on the East Coast, mostly New York City and Westchester County, and had a lot of different types of clients, mostly people looking to lose weight. I did have some athletes, and I started kind of getting into that. And most of the athletes really were coming to me looking to increase size or to increase speed. They want to do better on the field and had more performance issues. So when I started taking on these athletes, it really piqued my interest. And I started researching a little bit more on how I could kind of help them in athletic conditioning, athletic training. So my interest kind of led me down a path in strength and conditioning. So I decided to become a certified strength conditioning specialist through the NSCA. And at that point, I was able to work with some of these athletes, mostly soccer, football, track and field, little baseball, little softball. But I really enjoyed working on making them stronger and faster, working on, lots of biomechanical types of things that would be advantageous to them. And as I started doing more and more in this, obviously with sports, we have, eventually because somebody's going to get injured. And as a coach, I have to refer that person out to a specialist, usually a physical therapist or a physician to be checked out and then start a rehab program. So that kind of also led me down a path of research. I wanted to learn a little bit more about injuries and rehab. And I had a lot of soccer and football and track and field players. So I was getting a lot of lower extremity injuries, knee, ankle, and stuff like that. So again, as my research kind of put me down a different rabbit hole, a couple of years later, I went to physical therapy school, became a physical therapist, and worked for a couple of organizations in Connecticut and in New York, mostly outpatient stuff. So I was seeing a lot more general population, people who had either had an injury and needed rehab, or people coming in from doctor's offices who had a surgery, for example. They would come in and I would start rehabbing them. So I had a lot of experience with that. So that also helped kind of push me into that world of medicine. And as I started seeing a lot more patients post-op of surgical care, knees and ankles and stuff like that, that piqued my interest. And of course, as I'm a very curious cat, I'm going to definitely go down that rabbit hole. And I did, and learned as much as I can, and really was very fascinated with the surgeries themselves. So I just really wanted to enhance my knowledge with that. And I got a chance to go and shadow a couple of orthopedic surgeons and a podiatric surgeon. We had a case with an ankle fracture that had to be surgically corrected and then brought to rehab. So I really established a relationship with this podiatrist. Really enjoyed what he did, and I really liked his surgical types of stuff. And I asked to shadow him for a couple months because I was interested in possibly pursuing a medical career. And again, a couple years later, went down the rabbit hole again. and found myself in medical school studying to be a podiatrist. So long story short, I have a lot of experience, but I've gone through many, many rabbit holes, but my interest has just kind of peaked. And when my interest peaks, I just go down that road and led to another adventure. So here I am today, personal trainer, a strength conditioning coach, doctor of physical therapy, and now a doctor of podiatric medicine. And I'm about to start my residency.
I love
soon,
that.
So.
First question that comes to mind is, man, how do you sleep? That's a lot of school and that's a lot of work.
Absolutely. Sleep was an option at that point in time. Well, actually, it's kind of funny how when I went down my progression of professions, my sleep schedule became shorter and shorter and shorter. And we got to med school. There is no such thing as sleep. You want to pass or you want to sleep. That's your option. So, I've definitely learned one thing I've definitely learned through a lot of these experiences is time management. That's like so important. You read so many books and motivational speakers are all talking about time management. And there is some truth there because you definitely want to manage your time effectively so that you can do these things and also have a life and or sleep because that's very important. So it's been one heck of a journey and I really enjoyed every ounce of it. But always learning, always trying to improve myself every day. It's always been a process that's a lifetime learning process we all go through.
100%. And so speaking about time management, I think one of the largest pieces is that when it comes to having to manage pain, say even like sciatica pain or even any sort of medical condition, we all have limited time on this earth and we also have a limited time during the day. And so when people are looking for solutions, they're looking for something that's effective, but also time effective as well. And this is where I think the use of experts in various different specialties is key. And it's important for us to be able to identify who should we go to when we're experiencing various different issues. And so when it comes to podiatry itself, podiatry, as compared to say doctor in physical therapy, MDs, DOs, podiatry has its own credential, which is DPM. And a lot of people think, okay, all right, well, podiatrist, foot doctor. But I think that there's a lot of misconceptions about what you guys do. And so if you can share with us a little bit more about what podiatry is, so Sure. we can kind of look at it in its reference to even something like sciatica pain.
Sure. So a podiatrist is a medical professional. We call podiatric medical school. Just as the MDs have their medical school, it's called allopathic medical school, and they get an MD when they graduate. DO goes to an osteopathic medical school, and they graduate, they get a DO. We go to a podiatric medical school, and when we graduate, we get a DPM. Our scope of practice is centered around foot and ankle ailments, anything from trauma all the way down to kind of like a pain that comes out of nowhere, and how do you manage that? So, our expertise is surrendered around the foot and ankle. We also, depending on what state you live in, because there is some scope of practice issues with each state, we can treat everything up to the tibia tuberosity, which is that bone right in front of that the tibia bone. So mostly a podiatrist can treat an ailment such as plantar fasciitis, which is an example which can be managed conservatively. And usually goes away. But if that does become a problem, we can treat other more aggressively using either a corticosteroid shot or even possibly surgery if it is that extreme. We are physicians first. Basically, our patient comes first. So as a podiatric surgeon, which we are trained in, we start in school at a third year. We start learning about surgery principles, different types of tools that we use and different types of approaches that we can use to correct any surgical issues such as fractures of the ankle, fractures of the toes, any sort of infection. We're very well known for foot and ankle and lower leg infection control. Majority of our population in that kind of regards is diabetic patients, as diabetic patients unfortunately are prone to those types of infections due to their glycemic index can be a little bit out of control. And at that point, when there is a wound that comes onto their foot and ankle, we're the first to take a look at it, evaluate it, and then treat it appropriately as we can. So we do everything an MD/DO does as far as giving out medications. We do surgery. Some DOs are not, MDs are not trained in surgery, but we actually are. So we are staffed on most hospitals. We get a trauma call for the foot and ankle. We're woken up at 2 o'clock in the morning to go in and fix an ankle or a foot. So, we do fill those roles just as our MD and DO colleagues do. So we just to know we are specialized in the foot and ankle. That's kind of like our bread and butter. So, yeah.
And so, and thank you for sharing, because yeah, a lot of people aren't really quite sure. And I remember I've worked with a couple retired podiatrists as patients, and I'm always really intrigued in regards to what everyone's specialty and how everyone interacts within the healthcare ecosphere. And so let's talk about its relation, the foot and ankle, and its relation to sciatica pain. And so
Sure.
things that I've come across when I'm working with someone who's had sciatica pain for probably a long period of time let's talk about one specific condition I find to be pretty common is often say like bunions. And so like bunions and like the great toe area. So listeners out there, and Dr. Chittenden will probably elaborate on this, but if you look down at your feet, ideally you want to make it so that the inner edge of your foot is pointing straight ahead, which is lined up with your great toe. Now, if you look at the inner aspect of your foot and your big toe kind of juts out to the side where there's like a little bit more of an angle, that could be kind of like the early stages of a bunion. But those are the things that I would see, or that was one of the more common things that I would see with someone who would have say sciatica pain, but also their pain would be related to more that they wouldn't tolerate, say, backwards bending, and they would actually prefer more of like a forward bend because of just how things are aligned. So, Dr. Chittenden, if you could share with us a little bit more about what you've seen with bunions and what are some of the common things that could be contributing factors to why they're there. But then also, if we're looking up the chain, what are some contributing factors that you observed for people experiencing sciatica?
Sure, absolutely. So a bunion is actually a deformity which has an insidious onset most times, meaning that it basically worsens over time. So if you look at a bunion actually, as Dr. Mack has basically described, it is that angulation, that lateral angulation of basically the toe going no longer straight. And bunions, surprisingly, are actually caused by faulty biomechanics. They start in the foot. And a lot of that has to do with flat-footedness. So a patient who has a flat foot for a long period of time is going to have an altered biomechanical posture of the foot as well as a gait pattern. So when you're walking, as your biomechanics become less and less in neutral stance, we call, and more in a pronated stance, that's going to trickle down distally to the toes. And the toes at that point then are going to adapt a different posture than what the neutral posture of your foot should be. As a result, you start to see that angulation of the toe no longer being straight, but now kind of going out to the side, going toward the second toe, for example. And I know that people don't really look at where, how you're walking, but when we look at somebody coming in for consultation or examination and they have a bunion, we're observing that during the push-off phase, where basically is your last phase of stance, the patient tends to push off by basically angulating their foot out to the side instead of angulating it straight. So what happens is that becomes kind of like your norm, and it just happens. It becomes something that your body is going to compensate because of that pronation and that foot posture being out of place. There was a very brilliant podiatrist I actually got in touch with a couple of months ago. He came out with a theory. And he called it the biokickstand. And it basically takes a look at the posture of the foot. And the posture of the foot in a neutral stance should be even between three pillars, the first being the first metatarsal, the second being the fifth metatarsal, and the last one being the heel. So basically you form a tripod, and that should be an even stance. So as time goes on and you develop kind of a pronated stance, basically means that arch of your foot tends to start to drop and become flatter and flatter and flatter. That tripod actually becomes no longer in neutral stance. Now it's kind of angulated toward the pronation. He calls it the activated biokickstand. And as your foot becomes more and more pronated, and it is a progressive thing, as time goes on, you get older, the joints become, much stiffer as you get older. You might gain some mass. That bio kickstand is going to become much more pronated, and at point where now you have a dysfunction, you have a broken kickstand. The kickstand no longer is operating in a neutral position. As a result, the bunion can form because of that altered biomechanical state. Now, this in and of itself can start leading up to the chain. So now you start with this altered biomechanical stance and gait pattern. And now what people tend to do, and we see a lot of this when people have that angulated foot, their whole foot and ankle starts going into what we call external rotation. When external rotation happens, the tibia, which is the bone connecting the ankle, that starts to also externally rotate. And that going up the chain, we go to the femur bone, which also externally rotates. And there's issues with that as time goes on. There's something called trochanteric bursitis, in which the outer muscular band called the IT band will press upon a bursa, which is on basically the outside part of your femur, causing pain. There's a bursa there. That structure can actually cause pain. And, if you lie down on a couch on your side one day, watching TV, and all of a sudden, wow, I got that weird pain. Where's that come from? This is basically a contributing factor from the foot. Everything is translating up. So going all the way up to the hip, we get to the hip area where the sciatica nerve first originates. A lot of complaints and a lot of research has pointed to the reason of sciatica being a compression of the muscle called the piriformis muscle, which basically lies right on the outside portion of where that sciatic nerve runs down. So if that muscle, which happens to be an external rotator, and as I'd already explained, we have that external rotation of the foot going all the way up the chain, we get to the hip, and now we have that muscle, which is an external rotator, becomes tight, and it stays in that kind of tight, shortened position. After a while, it will cause compression, and then you have that sciatica, and then you start having that pain in that area. Sometimes it goes up the back, sometimes it goes down. Some people, especially for a long period of time, they'll feel that pain starting to come down all the way to the back of the leg, and they start feeling that discomfort. So a lot of people look at the back and say, well, you might have a disc issue or there might be a hip issue. But if we take a step back and really examine what's going on at the foot, we can start to kind of see a culprit starting all the way down there. And, again, when I tell people about this phenomenon, they're almost shocked. But in my experience and my experience in the years of physical therapy, now going in podiatry, and doing a lot of physical examinations and gait analysis, I definitely have seen these patterns emerging more and more. And definitely that's where I really start to see, I think it might be the foot and ankle starting all of this. So unfortunately, it just translates up. And then after time, the pain starts to come and we have that sciatica issue.
We are going to take a quick break to tell you about our awesome new program called the Sciatica Protocol. If you don't have the time to see a professional, but are tired of trying to figure out this recovery on your own, then the Sciatica Protocol is for you. Harness the power of a knowledgeable physical therapist through your phone. It takes no more than 7 minutes per day, and it is designed to help you recover as quickly as possible. It is simple to start, and all you need to do is log into ifixyoursciatica.com/the-sciatica-protocol and fill out the 9-question quiz to begin. The link for the program is in today's show notes.
Wow, that's an amazing explanation, Dr. Chittenden, because a lot of times people are saying, okay, well, I'm in this pain. I just need to get out of this pain. And then they're doing, say, a various different stretch or whatnot. So even if it's like, say, for example, the piriformis is in fact very, very tight. So they stretch the piriformis out. It's like, okay, my pain is relieved. The big question that us clinicians have to ask is, why is this piriformis? Why are these structures irritated in the first place? They don't just spontaneously say, hey, today I want to go ahead and give Joe sciatica pain, so I'm going to go ahead and tighten up this piriformis. And a large part of it is being able to say, why is this happening in the first place? And so looking further down the chain allows us to be able to understand, okay, well, what are these sources of dysfunctions and challenges that our body's going through, which results in these muscles being a little bit more tight? And so One thing that I've observed in people who say have bunions or flat feet as well is that they are limited in this motion called ankle dorsiflexion and great toe extension. So pretty much listeners out there, ankle dorsiflexion, if you're standing and if you were to be lifting the ball of your foot off the ground while using your heel as a pivot point, that is ankle dorsiflexion. And oftentimes I notice that for folks who are experiencing some sciatica pain, that's actually related to the fact that their back is too arched, and also have flat feet or some sort of bunion deformity. They have trouble actually lifting the ball of their foot off of the floor. But then also even the great toe extension, being able to pivot on that toe, which also really translates on over to that tripod that you were talking about, Dr. Chittenden. Triangles in physics world and engineering world is actually the strongest shape. And when you have that triangle, it allows us to have that stability, and we kind of lose that stability as that tripod starts to get lost, which then gets passed up through the rest of their chain. And so we talked about like bunions in say flat feet, and I think a lot of people are like, okay, well, it looks like I have that. It looks like I'm dressing my foot right now. Looks like I have a flat feet, or it looks like I'm having a bunion deform. Okay, I have a problem. What are some ways that, what are some easy, actionable ways that people can do or things to follow through that they can address a problem like this on their own?
Yeah, absolutely. So the first thing is to always, we examine the foot to see exactly where that dysfunction might be. As doctors, we always want to take the most conservative route, the easiest route, the less invasive route. So the first thing that I look at when I'm looking at a patient and I definitely observe a flat foot deformity. I definitely see the arch is not there. I see, that tripod has unfortunately really geared into that pronation. So we now have a broken kickstand. How do we fix that? The first thing I would definitely say would be an orthotic. Orthotic's job is to kind of actually spread out forces. So we have when your foot hits the ground, there is a force. Basically, your foot hitting the ground, we have a force of the foot hitting the ground. That's one force going down, and the ground coming back up. That's called the ground reaction force. That's pushing up against the foot. So if we are hitting the ground with, let's say, your heel is kind of, we call everted. Which basically means that part of the heel is coming down first, and then the rest of the foot kind of drops down in a position. What we want to do is we want to kind of spread out those forces and put basically a accessory object within your shoe, basically called an insert. We want to do is spread out those forces so that the foot can kind of evenly hit the ground together at the same time. So one very common ailment that people complain about, especially in the heel area, is plantar fasciitis. Plantar fasciitis is caused by compressing of the plantar fascia, one specifically in the medial area of the spot, which is where most plantar fasciitis begins. And it's because the foot's hitting the ground at that same spot over and over and over and over again, and that tissue is becoming extremely inflamed. So what we want to do, we call offloading that. We want to offload that point to the point where we can now spread out the forces of the foot hitting the ground as symmetrically as possible to basically even out that ground reaction force. So the entire foot now is absorbing the force instead of one specific point in the heel. So the first thing we want to do is definitely encourage patients to get an orthotic. My personal belief is that a custom orthotic would be better for a person who has a very specific ailment. You mentioned bunions. Again, as I said before, a bunion is caused by a biomechanical deficiency, and where you have the posture of the foot is no longer in that neutral position. So what we try to do with an orthotic is try to get that foot into a neutral position. The great thing with the custom orthotic, it can be customized to your foot. Everybody's foot's different. Everybody has a different ailment. Everybody has different issues. So you don't want to go to the store and just get something off the shelf because it's basically off the shelf. It's going to do a very general and very minimal job. So basically, if you have like a diabetic ulcer, you just don't go to the store and put a Band-Aid on it. Hope it goes away. What you want to do is seek the proper advice, seek the proper medical advice so that we can customize a plan to help you with specifically your issue. And that's what medicine is. Medicine is customized for patients. When a patient has an issue, you come and see a doctor, we examine you, We give you a prescription of what you need to do, whether it's medication, whether it's going to physical therapy, or in this case, an orthotic. So a custom orthotic is basically done. You go to a podiatrist. We have a special tool that we use. We basically measure your foot, and then we'll basically make a mold of your foot depending on what podiatry go to. There is things with an orthotic can be done through like a box. You basically put your foot in a box, and we basically catch the mold. Some podiatrists have much more sophisticated equipment where we actually will take a digital image of your foot, and then we can customize an orthotic based on the contours of your foot, where you're having your pain, try to build up that area. So again, our goal is to kind of, get the foot to be in a symmetrical position. So when it does hit the ground, it hits the ground, nice and evenly, and takes the pressure off the areas that you are experiencing. As far as a bunion is concerned, if you do have a bunion and it progressively gets worse over time, it's an insidious onset. Unfortunately, the only way to really correct a severe bunion is through surgery. That does take, again, a physical examination by a podiatrist. At that point in time, we would then go over, what we think we should do. There are many procedures that we can do, depending on what specifically the deformity is. As far as preventing a bunion, again, biomechanically speaking, a good orthotic will definitely do it. Also, with the orthotic, I also suggest biomechanical exercises. You can go to a physical therapist. The physical therapist will be able to evaluate exactly what's going on and give you proper specific exercises that you can do, not only for the foot and the ankle, but also for the entire kinetic chain. As I said before, things start at the feet and then translates up over time. So not only do you want to fix the foot ankle problem, you want to make sure that everything above the foot and ankle is in a good posture. Make sure that you are getting good, strengthening and stretching to the proximal segments, the hip, the knee, and everything is in line with everything. So it's a process, but it's definitely a step-by-step process. It's definitely manageable. We've had great results. There's great research out there to support both an orthotic and the use of biomechanical exercises, therapeutic exercises given by a physical therapist or strength conditioning coach that will definitely help your problem. So there are solutions. It's just a matter of just, taking it on yourself to seek out those solutions, go to a podiatrist, go to a physical therapist, and get these things checked out. If you're having pain, don't wait. It's only going to get worse. Just go in and let us take a look at you and see what we can do for you.
Right on. Really amazing action steps. You brought up a very interesting point about plantar fasciitis specifically. You were talking about it was really an overload of the plantar fascia, especially on the medial side. But and you said like one of the orthotics you use is actually as a way to offload that fascia itself, which then, as you were saying, that made me think about one of the very common ways to treat plantar fasciitis from like a rehab standpoint. I see this a lot. I don't recommend this, but is to like take a lacrosse ball or like a roller and roll out the crap out of the bottom of your foot. And to me, when you're having a plantar fasciitis, you're having an irritation of that tissue. It didn't make sense to me to massage an already irritated issue. And so what are your thoughts on that, if you don't mind me asking?
Sure. Actually, I'm gonna switch hats and go to the physical therapy mode. There is something called transverse friction massage. I'm sure you've heard of it. They teach this in physical therapy school. It's been going on for, I don't know, over 50 years or so, something like that. And basically the philosophy behind that is if you massage the area that's inflamed, you basically restart the inflammation cycle, and we get more leukocytes and neutrophils and all these different cells into the area to kind of redo the whole inflammation. Here's the issue with that. I think that's a terrible idea, only because of the fact that your body has already done that. And I can tell you, especially if you're a young guy or a young gal, and you're healthy otherwise, your inflammation system cycle has already done that. You've already had the process of inflammation, proliferation, and then you have your scar in that. Redoing that is not going to make it better. In my experience as a physical therapist and as a podiatrist, there are many different other options. Obviously, an orthotic, as I talked about, is one of those options. Another option is stretching and strengthening the area, specifically in the deep plantar muscles themselves. There are actually 4 layers of tiny muscles that are actually in the sole of your foot, and over time, as you get older, and if you do gain weight or become more active, these muscles tend to become weak. And so it's up to a rehab perspective to strengthen these muscles. We want to stretch muscles, specifically around the ankle, the lateral muscles, also known as the peroneal longus, peroneal brevis. We want to stretch those out. We want to get those more mobile. We want to definitely strengthen the area of where we're getting that inflammation, because the tendonitis, the tendinosis area is an area which is getting overloaded by specific forces. But the other muscles around the foot are kind of on vacation because they basically have weakened, they let go, and now they're no longer functioning and really contributing to that functional posture I was talking about before. So that is definitely a process. Not only do you need the orthotic, but you definitely need to have the rehabilitation in there. You want to strengthen all those little plantar fascia muscles. And you go to a good physical therapist, and they have tons and tons of different ways to do it and different approaches. As Dr. Mack has already explained, that doing that again and over again with your finger. They got tools out there. I've seen the Graston tools where they constantly going over and like that, and you're just re-inflaming it, and you're going to be in more pain later on. So I never even understand that concept to begin with. Obviously, we had to learn it as physical therapists, but there are many other solutions, and with research has already shown that the strengthening portion is very underutilized. And stretching is out there. A lot of podiatrists always are giving stretching exercise to patients, but I think that the thing that the component that's missing is that strengthening part. Really strengthening the plantar fascia muscles, the ankle muscles, using TheraBands and all kinds of other stuff. We can really do a much better job, and we can really prevent all of these ailments very easily.
Absolutely. I appreciate it, Dr. Chittenden, and for you to be able to share that, because it really baffled me. It's like something's already inflamed, you're going to massage it even more, and it kills me. And so looking at this whole thing, one thing that I have done when I'm working with my patients, especially if they are having some foot issues, is, and I'm all about simplification. And one of the things I found to have great success is actually helping, like, say, for example, someone has bunions or plantar fascia or flat feet. They often stand with their feet turned out, like kind of like a duck walk position. And I'll often say, okay, so your orthotics will be great. You can wear them, but then also try walking or try standing with your feet pointing straight forward. And it's not necessarily having so that your toes are facing straight forward, because for the most part, people's toes are a little angled out anyway, but making so that the inner edge of the foot is facing straight ahead. And the moment I have people do that, a couple things happen. Number one, they feel like they're pigeon-toed. But then also number two, they actually notice that their abs start to kick in a little bit more. Their back and pelvis feel a little bit more stable. And so as you were talking about, it's like the moment that those feet are externally rotated, the tibia externally rotates as well, everything starts to kind of collapse inward, which then actually changes up the pelvis. So I often tell my clients to say, listen, we have these solutions from a very small micro level, but from a macro level, this is what we need to be able to do from a behavior standpoint. So as you wear these, it doesn't give you permission to do the same thing that you've always been doing, but it allows you to be able to just distribute that force, as you were saying. And we need to focus on, okay, let's have it so that the feet are facing straight. And from a neurological standpoint, truth be told, we should be able to get in all various different positions without issue and without injury. But if we're in a position for a long period of time, that's when our bodies and our nervous system says, hey, body, I've had enough and I need to change this up. So even just simply turning those feet forward, not necessarily in, but more so forward, has a huge impact. But it definitely gets compounded by the work and expertise that you podiatrists do. So I just wanted to share that, and I appreciate you, everything that you're doing and what your profession does.
Absolutely. And as I said before, and most people know this by now, that, in medicine, we have obviously the medical doctors, but we also have physical therapists that are extremely helpful and a very integral part of treating patients. So when we have foot issues like this, and we treat them, they basically come to our office, we treat them, but I always will send a patient to physical therapy. And in some cases, I'll actually write in the script exactly what I want done, as far as, not only do the foot and the ankle strengthening and stretching, but I also want you to make sure that, you take a look at the hip, make sure that they got the strength in there, work on some VMO strengthening, work on some, even isometric, even short arc quads for some quad strengthening, hip strengthening, definitely. All of these components, all make up the chain. Okay. The feet are very important because they are the base of the chain. So as you're going up the chain, every component, we call a link, which is basically each joint, contributes to everything below it. So it's good that you are definitely taking care of the feet, but don't forget that the rest of the body needs to rely on the feet. So you want to make sure that you have proper flexibility, you need to have proper strength. And with sciatica, obviously stretching the piriformis is going to be an option, but also strengthening those glute medius, strengthening the glute max, those all contribute to that alignment, as Dr. Mack was explaining, that everything needs to basically be in that neutral alignment. And if one kink of the chain is out of whack, it's going to basically translate up the chain eventually. So I definitely make sure that any physical therapist is looking at every aspect of a chain, not just foot and ankle. So absolutely great point. Great point to make. But everything is a system. Everything needs to work together from top to bottom.
And so as these listeners are hearing the benefits of working with a podiatrist, I guess like the big thing is that, and I've experienced this recently trying to find a new doctor. I'm like, I don't know, like as I'm trying to find a new doctor, there's so many doctors in my area, but also a bunch of doctors are not taking new patients. And so if the listeners are thinking, okay, I should see a podiatrist and then they should start doing the search, what are some of the qualities or things that they should be looking for, knowing that the podiatrist that they're going to work with is actually going to be the right podiatrist for them?
Yeah, that's a good point. Yeah. As I said before, we're all trained, the same when we get out of podiatry school. But there are specialties within our field. There are podiatrists that focus on surgery only. There are podiatrists that focus on wound care only. There are podiatrists that focus on biomechanics and orthopedic, different types of medical equipment that a patient could use or need. So if you are looking for a podiatrist, if you need a surgery, you want to definitely go to a podiatric surgeon that has possibly either done a fellowship or has specialized in a specific surgery. There are podiatrists who focus on just the toe surgery. There are podiatrists that focus on just ankle surgery. So you want to be just cognizant of exactly, who you're dealing with. You want to take a look at their profile, want to see where they've possibly done a fellowship in. That will give you a good indication that they're specialized really in there. If you need an orthotic or if you need somebody to do a biomechanical examination, you definitely want to look to see if they've either done a fellowship or they have some past experience or past credentialing that basically gives them that ability. So it's always very prudent to, when you're looking for, whether you're looking for a podiatrist or a primary care doctor, you want to definitely take a look, take some time, take a look at their bio, see exactly, what kind of experience they have, what they have focused on, if they have a specialty, what that is, where they train, fellowship-wise, if they have credentials, such as, if they had strength and conditioning background, a PT background, or an athletic training background, that probably would help you, especially if you're an athlete looking for, a specific issue with your ankle and foot. So definitely being very prudent to, kind of shopping around, just like you would shop for a car. You want to definitely spend the time, research to see, what car would really suit you, what kind of ratings they have. Same thing with doctors. We have something called, I think it's called MD Vitals, and it's a website. You go on there and you can check out the doctor as far as, how long they've been in practice. You can take a look at a patient's reactions. There's like a section on the bottom, and you can actually read about, how the doctor treated them and what their expertise is. So that probably can help you out. But there are definitely a lot of tools and a lot of resources out there. There's a ton of stuff on the internet. I'm sure people know about that. But just be prudent of what doctor that you need, what specific problems that you need, and just kind of look for that person that specializes in that.
I love it. Thank you so much, Dr. Chittenden. This information is so valuable. I learned a lot today too, and just being able to see how the foot really interacts, because in my head, and also what I've researched, I said, okay, yeah, the foot has a huge role, but to be able to hear it direct from a podiatrist's mouth, as well as a biomechanist like yourself and physical therapist, there's a lot of weight to what you bring. And I'm very thankful for you taking the time out of your Saturday to be able to share your knowledge with the world. So for the listeners out there who are thinking, okay, yeah, this is really helpful, but I still have a couple of questions. What's the best way for people to get in contact in the event that they just want a little bit more information?
Sure. Basically, I'm on Facebook. I'm on LinkedIn. You can look up my name. If you want to send me an email directly, my email is Keith, KEITHFIT 99 at hotmail.com. Shoot me an email. I'll try to get back to you as soon as I can. I possibly can. Sometimes I get a little busy, so give me about 2 or 3 days, but I will definitely get back to you. So any questions, any concerns, please let me know. Be more than happy to talk to you.
Beautiful. Thank you so much, Dr. Chittenden.
Thank you very much for having me. I really appreciate it, and I really had fun today. Thank you very much for this opportunity.
Thank you so much for tuning in. We hope you got some help from today's podcast. And for more info, check us out at ifixyoursciatica.com. Have a fantastic and pain-free day.
No patient-therapist relationship is formed by listening to this podcast. We are not providing medical advice, and all information should be confirmed by a medical provider.